If you have any questions, you are welcome to interrupt me, and if not, you can wait until the end and ask your questions at the end. So this is the first time I do this on the web, so I'm used to interact with my fellows all the time and ask questions as I talk. So this is going to be new for me. So as you know, the primary function of the respiratory system is to supply oxygen and to remove CO2 to meet the metabolic demands of the body. So the lungs will do this by three main mechanisms. The first one is ventilation, which is the movement of air between the atmosphere and the alveoli. The second one is perfusion, which is the flow of blood through the lungs. And the third one is diffusion, which is the transfer of gases between the alveoli and the pulmonary circulation. So today we are only going to...
Sorry, Dr. Alvaro, sorry to interrupt. There is a lot of background noise. I think people's mic is on.
I think you have to mute your microphones, guys. Everybody mute the microphones.
Dr. Alvaro, so what you can do is, as a starter, you may be able to mute everyone's microphone.
Okay, I don't think we have an option here to mute everybody's microphone. So please do that if on your end. Is this better?
Yes.
So so today, as I said, I'm going to talk only about ventilation, and maybe in future talks we'll talk about perfusion and diffusion.
This meeting is being recorded.
Okay, so to be able to move air inside and outside of your lungs, you need to create a pressure gradient between the lungs and the outside. The lung cannot expand by itself. It can only move passively in response to external pressures. There are two ways the air can get into the lungs. The one is to create a positive pressure at the airway opening to push air into the lungs. And that's the way that mechanical ventilation works, by increasing the positive pressure at the mouth. And the other way is to create a negative pressure within the lung, as occurs during free breathing humans. So when the alveoli becomes, the pressure in the alveoli becomes lower than the atmospheric pressure, the air moves into the lungs. And as we can explain now, the volume changes lead to pressure changes, and pressure changes lead to flow of gases to equalize those pressures. I'm going to explain that right now. So there's a law that was described by Boyle in 1662 that described how the pressure of a gas tends to increase as the volume of the container decreases. As you can see, this equation shows that as volume 2 increases here, the pressure 2 will have to decrease proportionally to maintain the equality of the equation. Needs to increase, as you can see in this graphic. So if you translate that into the lungs, we know that air flows from high to low pressure as long as the structure is able to change volume. So this will be an example here on the left of a lung at the end of inspiration, in which the pressure in the atmosphere is equal to the pressure inside the alveoli. Therefore, there is no movement of air. During the beginning of inspiration, the volume of that chest increase, so the pressure inside decreases, so the alveolar pressure becomes lower than the atmospheric pressure, and air will move into the lungs. This is an example of an experiment that explains very easily how the air moves in and out of the lungs. On the right side here, we have inspiration. We have a container that has two balloons. They're connected to the outside by a tube. And here on the bottom, we have a sheet that represents the diaphragm. So if you do this experiment, you pull this sheet down, and that will increase the volume inside this container. And because the volume increases, the pressure inside this container will go down, as we explained before, and it will become lower than the pressure outside. So the air will move in and will inflate these balloons. On expiration, you return that sheet back to its normal position, so the volume of that container will go down, the pressure therefore goes up, and that will compress the balloons because the pressure now inside the balloons is higher than the pressure outside, and the air will move out. And this is the way basically our lungs work. So to initiate a spontaneous breath, in green on your left, the first thing that happens is a change in volume. Because of that change in volume, that will create a pressure difference between the atmosphere and the alveoli. So the mouth pressure minus the alveolar pressure is what we call the transpulmonary pressure. The alveolar pressure becomes negative in relationship to the atmospheric pressure, and therefore the air will move into the lungs. So this is the physiological way we get air into our lungs. Now, the other way we can get air into our lungs is when we do mechanical breath, when we put a baby on a mechanical ventilator. In that case, the first change is not volume change, it's a pressure difference. And that's created by positive inspiratory pressure that when you subtract that from the PEEP, you create a pressure difference between the mouth and the alveoli, and that makes the air going into the lungs, and that then will create a volume change. So as you can see, mechanical ventilation is not a physiological way to expand the lungs. It's very unphysiological. So you can see the difference. One is triggered by volume change, and the other one is triggered by a pressure change. So let's talk about the pressure relationship in the thoracic cavity. Intrapulmonary pressure is the pressure in the alveoli, which decreases or increases during respiration, but always eventually equalizes with atmospheric pressure at the end of inspiration and at the end of expiration. The intrapleural pressure is the pressure in the pleural cavity, and it also goes up and down with during respiration, but it's always about 4 millimeter mercury less than intrapulmonary pressure, and we explain why that is. So if I have you here with me, I would say, well, I will ask you, why is the pleural pressure always negative and less than the intrapulmonary pressure? And the answer to that relates to the natural elasticity of the lungs. It's called the inward recoil. Second is due to the surface tension of those lungs that tends also to collapse the lungs. And the third force, which is the opposite to the first two, is the natural elasticity of the chest wall, which is the outward recoil. So when we talk about elastic recoil, we need to understand what elastic recoil means. And elastic recoil is the tendency of a stretched object to return to its original shape, and it behaves like a spring, a coil spring. Elastic structures like springs are deformable, but return to resting unstressed volume. And different springs have different recoil properties. So when you look at these springs in the lungs and the chest wall, and then together, when you look at the spring in the lungs are, imagine yourself holding a spring with your hands, with your two hands, and you're grabbing the two ends of that spring and you overstretch that spring. So what's going to happen when you release, when you let it go? The spring will close down and will shorten again. It will tend to go back to its resting volume. That what happened to the lungs. They're in a stage of overstretch. It's like a spring that is overstretched all the time and tends to recoil back to a smaller volume. Now, the chest wall is the opposite. It's a string that you're holding in your hands, but you are compressing that string. Okay, so you have that spring compressed. So what happens when you release that spring? The spring will tend to get bigger, longer, and will stretch out. Okay, so that's the way the chest wall is behaves all the time. It's like it's compressed. Now, when you put these two together, like it happens in real life, it creates a force. When you connect them, it will show that one force is pulling in one way and the other force is pulling the other way. So the lungs tend to pull the pleural space in one direction while the chest wall is pulling the pleura in the other direction. And that creates a negative pressure inside that pleural space. And that negative pressure is there as long as those two forces opposite to each other. So what happened when you, for example, developed a pneumothorax? So here we have the normal position of those springs, and the outside in the red are the springs of the chest wall that are compressed, and they're actually pulling the pleura outside. And on the inside, in gray, we have the springs corresponding to the lungs that are overstretched, and those springs will again pull the pleura on the opposite direction, and that creates an FRC. Now, what happened when you introduce air into that pleural space? Well, what happened is that the pleural pressure becomes equal to the alveolar or atmospheric pressure, and then the lungs will collapse and the FRC will decrease. So here is a example of the whole chest, putting these two springs together. In the middle, you have the lung recoil springs that tend to bring the pleural pressures inward. And on the outside, you have the chest wall recoil springs that tend to pull that pleural space in the opposite direction. And as long as you have those two forces opposing each other, then you have a negative pressure inside that pleural space. So functional residual capacity is what is formed from those opposite elastic recoil forces of the lungs and the chest wall are in equilibrium. And the things that will determine the size of that functional residual capacity is mainly the elastic recoil and surface tension and the surfactant and the chest recoil. The elastic recoil and the surface tension will pull will make that lung deflate, while the surfactant and the chest recoil will make the lung expand. And as you know, the main problem in our premature babies is not so much the elastic recoil and the surface tension. It has to do with the lack of surfactant and the fact that the chest recoil is a decrease. Surfactant deficiency is due to prematurity, and chest recoil decrease is because the chest wall is immature, doesn't have bones, so it's very compliant, and it doesn't have the same opposite effect as a normal mature chest wall. So what happens is the pressure, the forces that tend to collapse the lungs are significantly greater than the forces that oppose that collapse. And that's why premature babies have trouble breathing when they have surfactant deficiency. So let's talk a little bit about what we call the transmural pressures. The transmural pressure is the difference in pressure between the inside and outside of an elastic structure. So pressure inside minus pressure outside. It's also same as the distending or recoil pressure, which is the difference between the two opposite forces. Okay. So here we have number one is the atmospheric pressure, which is the pressure that we are in the middle of. Is measured in millimeter of mercury. It's about 760 millimeter of mercury. Depends on the temperature and so on, but it's roughly 760 millimeter of mercury. 2 is the alveolar pressure, which is usually equal to, at rest, the atmospheric pressure, which is 760. And some people call that zero pressure, or 0 centimeter water, which is basically the same as saying same as atmospheric pressure during the end of expiration and the end of inspiration. And the third one, the number 3, it's the pleural pressure, which is the pressure that inside those two layers of pleura. So A is what we call the transpulmonary pressure, which is the difference between the alveolar pressure 2 minus the pleural pressure 3. And that's the pressure that actually makes the lungs to expand or to collapse according to the level of that difference. Okay, so the transpulmonary pressure is the difference between the alveolar pressure and the intrapleural pressure in the pleural cavity. Since the lungs have a tendency to recoil inwards, inflating the lungs requires an increase in transpulmonary pressure. That transpulmonary pressure can be increased 2 ways. You either increase the pressure inside relatively to the pressure outside the lungs, and that's what you usually do with a mechanical breath. You basically increase the pressure outside in relationship to the pressure in the alveoli. The second way is by decreasing the pressure outside relative to the pressure inside the lungs, and that's the way we breathe spontaneously. The second transmural pressure is the transrespiratory pressure, which is the difference between the alveolar pressure and the atmospheric pressure. So the transrespiratory pressure is the gradient, the difference between the atmospheric and the alveoli, and is responsible for the actual flow or gas in and out of the alveoli during breathing. And the third transmural pressure that is important to describe is the C, which is a transthoracic pressure, which is basically the difference between the pleural pressure and the atmospheric pressure, and represent the total pressure required to expand or contract the lungs and chest wall. So let's talk a little bit about the pleural pressure, which is extremely important to understand how the lungs expand or deflate. So the pleural pressure is always negative. Under physiological condition, unless you have a pneumothorax, the pleural pressure is always negative. The negative pleural pressure is created, as I explained before, by the recoil forces of the lungs and chest wall pulling on that space and create that negativity, that vacuum. With the expansion of the chest wall, the pleural pressure will become more negative and the lung will expand. So here we have an example of how to calculate the pressure, the difference between the three different compartments. Here we have the lung surface, the pleural space, and the chest wall surface. So the pressure inside the alveoli at rest is 0, or is 760 millimeter mercury, which is the same as atmospheric. The pressure inside the pleural space is always negative, about -5 or 5 centimeter water lower than the alveolar pressure. And the chest wall surface is same as atmospheric pressure, or 0. So when we calculate the lung recoil at FRC, we basically do a simple formula that subtract the alveolar pressure minus the pleural pressure. So the alveolar pressure is 0, the pleural pressure is -5. So when you do 0 minus -5, you end up with 5, okay? Because minus minus is plus. So you end up with 5 centimeter water. If you want to do it in millimeter mercury, you can say the alveolar pressure is 760 millimeter mercury. The pleural pressure is 755 millimeter mercury. So when you do 760 minus 755, you get 5, positive 5. So that 5 centimeter water difference in pressure, positive, keeps the lungs from collapsing. Okay, it's basically pulling that lung open using a 5 centimeter water force. Now, when we calculate the chest recoil at FRC, now we use the difference between the pleural pressure minus the atmospheric pressure. So it's the opposite. Okay, so the pleural pressure is -5 and the atmospheric pressure is 0. So when you do -5 minus 0, you end up with -5. Okay, so the chest recoil at FRC is negative, and that's why the chest wall tend to expand when you release that pressure. So you need negative pressure to keep the chest from expanding, and you need a positive pressure to prevent the lungs from collapsing. I hope this is clear. Okay, this is very important. Okay, so let's review in a simple way the different stages of inspiration on expiration. So at rest, we have an alveolar pressure that equals atmospheric pressure, so 0 and 0. So there is no air movement. There is no difference in pressure. Therefore, nothing moves in and out. Okay, so that's the beginning of at rest. Now, when we start inspiration, the way inspiration starts is by contracting the diaphragm. So when we contract the diaphragm and the intercostal muscles, what we do is we pull the diaphragm down and expand the chest cavity. So we increase the volume of that chest cavity by pulling the diaphragm down and the rib cage out. So when we do that, volume increases, and when the volume increases, as we explained before, what happens to the pressure? The pressure goes down inside that cavity. Okay, so thoracic volume increases because of the contraction of the respiratory muscles. That will decrease the thoracic pressure, so the alveolar pressure now becomes negative. Okay, now the intrapleural pressure also will go down. It was -5, now it will become -8. Okay, because you have increased volume there, so the pressure inside the pleural will also becomes more negative. Okay, and now the pleural force is greater than the lung recoil force. Remember, the equilibrium was only -5. Now you have -8. So you have an excess of pleural force over lung recoil force. And that will make the lungs to expand. Okay? Now, during inspiration, then, what happened now is, because the lung expand, the alveolar pressure becomes negative. So in relationship to the atmospheric pressure, now it's not 0 anymore, it's -1. So that makes the transmural pressure or promote or produce a transmural pressure between the atmospheric and the alveoli, and then the air moves in. At the end of expiration, we have the alveolar pressure now increases because you get air into the alveoli to the point in which the alveolar pressure becomes equal again to the atmospheric pressure, and then that's when the flow of gas stops. Okay, so at the end of expiration, you basically have, as you see on the top, FRC plus the tidal volume. That's what you have at the end of expiration. Okay, so you have achieved a new equilibrium in which the pressure is similar to the recoil pressure again, but this time is not just FRC, it's FRC plus the tidal volume, the extra air that you have acquired inside the lungs. Okay, so how do you start expiration? Now we know expiration is a passive, is passive in humans, and basically at the start of expiration, you basically return the diaphragm to its original position at rest. So when the diaphragm relaxes, the volume inside of that chest cavity goes down again. Okay, so the relaxation of the diaphragm produces decreased thoracic volume, and that, as the Boyle's law, will increase thoracic pressure. So now all of a sudden the intrapleural pressure goes up again, and the pleural force that is keeping the lung open will also decrease, and the lung will start deflating. Now, what happens when the lungs start deflating? The pressure inside the alveoli goes up and becomes positive in relationship to the atmospheric pressure. So now it's +1. Okay, so increased alveolar pressure +1 becomes positive in relationship to the atmospheric pressure. So you have created a transmural pressure, and then the air moves out of the lungs. Okay, I hope this was clear. So again, it's all physics. Okay, all relationship to pressure differences and volume differences. Okay, so if we want to see how the volume and the pressure changes during inspiration and expiration, we can see that during spontaneous breathing, the first thing that happens is an increase in volume in the chest cavity during inspiration. Okay, and that volume keeps going up and up and up until the end of inspiration. Now, when this volume goes up, the pressure in the pleural space becomes more negative, right? Remember, when the volume goes up, pressure goes down. So the pleural pressure becomes more negative, goes from -5 to -8. Now, when we look at the alveolar pressure will also decrease during inspiration, okay? And it will go back to 0 at the end of inspiration. And the reason it goes back to 0 is because you have air now going into the alveoli. During expiration, the first change that occurs during expiration is that decrease in the volume of the chest cavity. That's because the diaphragm goes back to its relaxation position. When the volume goes down, the pressure starts going up in the pleural space and in the alveoli. So the alveolar pressure becomes positive in relation to the atmospheric until all the air is out, and you get a new equilibrium at the end of expiration in which the alveolar pressure is equal to the atmospheric pressure, and the flow of air stops. As you can see, the difference between the alveolar pressure and the pleural pressure is a transpulmonary pressure. And as you can see, that pressure is almost maintained throughout the inspiration and expiration. Okay, there's always about -5 between those two pressures, and that keeps always the lungs opening or deflating, depends which way it goes. Okay. Okay, so let's talk about now some terms that will help us to understand a little bit more about mechanical ventilation and how we ventilate babies. So one important concept is the concept of compliance. Now, compliance is a measure of stretching or distensibility of the respiratory system. Specify how easy is to stretch or distort the lungs and chest wall. Okay? And the formula that we use for compliance is change in volume for change in pressure. So how much the volume of the lungs change when we change the pressure. Okay? And the normal value for a newborn baby is between 1.5 and 2 mLs per centimeter water per kilo. Okay? So basically, during normal breathing or mechanical breathing is basically the difference between tidal volume over driving pressure. Okay. Now, there are things that we know affect compliance of the lungs. The most important things that affect the compliance of the lungs is first, the elasticity of the lungs. Second, the surface tension. And third, the elasticity of the chest wall. So, as we know, in premature babies, as we explained before, elasticity of the lungs is usually okay, it's normal. The surface tension, if you have enough surfactant, is also not a problem, but becomes a significant issue when you don't have surfactant, because surfactant is the only way we have to decrease the surface tension in the lungs. So when you are surfactant deficient, then your surface tension becomes a powerful force that will change the compliance of your lungs. And the elasticity of the chest wall, as we mentioned before, is also a problem in preterm infants because of the lack of ossification. And the chest wall is usually very compliant, therefore is producing less opposing force to the expansion of the lungs. So the tendency in premature babies is for those lungs to collapse more than in adults. The other concept that is important when you ventilate baby is the concept of time constant. Now, time constant is the time necessary for the alveolar pressure to reach 63% of the airway pressure. You can use volume or pressure, it doesn't matter. But it's that time that you need to reach 63% of that airway pressure. Under normal conditions, you need 3 to 5 time constants to reach 95 to 99% of that pressure. Okay. Now, to put it in a simple terms, the time constant is a measure of how quickly the lungs can inhale or exhale, how quickly the lungs can get rid of that air, or how quickly the lungs can get that air into the alveoli. Okay. Now, the formula for time constant is compliance times resistance. Okay, in normal newborn babies is about 0.12 seconds. Okay, so if you need 3 to 5, you basically with 0.3 to 0.4 seconds, you basically in a normal condition you can fully get air into the alveoli, and you can fully eliminate that air from the alveoli during expiration. Okay, now as you can see in the formula, when your compliance is high and your resistance is also high, your time constant will be very, very long. Yeah? When your compliance is very low and your resistance is very low, your time constant will be very, very short. This is extremely important when we ventilate babies. Okay, so you need to be sure that you use the right inspiratory time and the right expiratory time to avoid problems when you ventilate. Okay, if your inspiratory time is not long enough, you may not reach the alveoli with your air, and your flow, your tidal volume. You may end up with decreased alveolar ventilation and decreased mineral pressure. When your expiratory time is too short, you may end up with air trapping, and that may actually cause increased dead space and also increase mineral pressure because your lungs become bigger. Okay, so classical examples of a very short time constant is an infant with RDS or surfactant deficiency. An infant with surfactant deficiency, the main issue is the compliance. The airway is normal. So these babies have a very low compliance, but their resistance is normal or low. So when you have a low compliance and a low resistance, the time constant is very, very short. That's why it's very difficult to produce air trapping in a premature baby with pure RDS, even if you use very, very, very high frequencies with very short TIs and very short TE. You can put a baby on high frequency ventilation using very short TIs and very short TEs, and you're not going to get air trapping very easily. Why? Because the time constant in a baby with RDS is very, very short. Opposite to that, we have the example of a baby with meconial aspiration or BPD. Not so much compliance, but it's persistence. Those infants, especially those with meconial aspiration, the resistance is quite high. And the compliance usually, because there is no surfactant deficiency, the compliance is not that low. So you end up with a normal compliance or slightly high compliance and a very high resistance. So when you multiply the two, you end up with a very long time constant. So in those babies, it's very easy to create air trapping. So if your TI is not long enough or your expiratory time is not long enough, you may get into trouble. That's why it's not a good idea to use very high frequencies or rate when you are ventilating babies with BPD or meconial aspiration. So as I said, if inspiratory time is too short, you have an incomplete inspiration, your VT will decrease, your mineral pressure will decrease, and you will end up with increased CO2 and decreased O2. So hypoxemia and hypercapnia. When your expiratory time is too short, you end up with an incomplete expiration. In that case, you end up with two issues. Your compliance will go down and your mineral pressure will go up. And also you have increased dead space. That will create mostly a problem with CO2, so hypercapnia and decreased cardiac output because you have air trapping and hyperinflation. But because your mineral pressure goes up, usually the oxygenation is not an issue. So this is a typical example in which you have a baby that all of a sudden has a very, very high CO2s and is still in room air. Oxygenation is good. So you always have to think about air trapping. Okay, so things that determine oxygenation is usually due to change in FiO2, concentration of oxygen, and the volume of those lungs measured by mean airway pressure. Things that determine CO2 elimination is due to alveolar ventilation. And the formula is minute ventilation is VT times frequency minus dead space. So when you have a ventilation perfusion abnormality, if you have a high ventilation perfusion ratio, the classical example is you have an increased dead space, the main issue here is decreased CO2 removal because your alveolar ventilation goes down. Okay, so you take a lot of your tidal volume away because of the increased dead space. Okay, oxygen in general is not affected unless you have you're compromising perfusion of those lungs. But again, because when you have increased dead space, your mean airway pressure goes up and oxygenation usually is not affected right away. When you have low VQ, that's the opposite, then you have usually atelectasis. In this case, the most important element affected is oxygenation. You have decreased oxygenation, usually because you have a right to left shunt inside the alveolus. In these cases, CO2 usually is not significantly affected unless the atelectasis are very severe and you have decrease in compliance as a consequence of those atelectasis. In that case, then you end up with CO2 problems. So this is a graphic that shows the relationship between the pressure and the volume. It's measured as dynamic compliance. So your inspiration, you have two important pressures. that determine the expansion of the lungs. The first one is called the critical opening pressure, in which you have significant alveolar recruitment and you have overcome airway resistance. And that's where the compliance of those lungs increases. Then you have a second pressure on the top. It's called critical maximal pressure, in which you achieve almost maximal volume of those lungs, and the pressure just build up in the lungs without creating increased volume. And then on the way back during expiration, you have another pressure point, which is the critical closing pressure, in which you tend to deflate the lungs beyond FRC and you tend to lose volume. Okay, so the part of the curve that is on the top is called beaking or overdistension, in which you have very little change in volume with increased pressure, and you need to avoid that. And the lower part is when you have significant atelectasis with de-recruitment, and you tend to lose volume at the end. So ideally, again, in a normal condition, you want to be ventilating babies in that middle safe window to avoid overdistension and to avoid atelectasis and de-recruitment. So I'm going to give you a few examples here at the end to see how ventilating the lungs at different portion of the compliance curve can change significantly the state of the lungs. So here we have static pressure compliance curve. So let's say you are ventilating a baby with a PIP of 20 over a PEEP of 7. Okay, so you have a delta P above 13, correct? Okay, that delta P of 13 gives you a tidal volume of 8.7 mLs. Now, compliance, remember, was tidal volume divided by delta P. So if you divide 8.7 divided by 13, you get the compliance. That in this case is 0.67, which is low, because you are ventilating this baby on the upper part of that compliance curve. So just by decreasing the PEEP to 6, look at what you will happen. You want to maintain the same delta PEEP. So you go down to 6 in the PEEP, and you're going to go down to 19 on the PIP to maintain that delta P of 13. Now, just by doing that, you will see your tidal volume has increased 40% because your compliance now has moved to the steeper part of the curve, and the compliance now is up to 0.95. So the compliance have increased 40%, and that allows you to increase your tidal volume by 40% just by decreasing the PEEP by 1, just moving that ventilation to a steeper part of the compliance curve. Give you another example here. We have a 28-weeker. That the X-ray, 1.5 kilos. You've given surfactant at birth, and now the baby is 8 hours old. And you can see that X-ray. If anything, that those lungs are a bit hyperinflated. You have a flat diaphragm. Your heart is a bit small, and I would say this is a bit hyperinflated. So when you do, you have this baby on ACVG rate of 60, people 6. The volume you are using is 4.8 per kilo, and your PIP that the ventilator is using to deliver that volume is 24. And that's a bit too high for a premature baby. So you're concerned about that PIP. Your TI is 0.3 seconds. You're in room air, so you are not having proper oxygenation. You do a gas, and the pH is 7.33. Your CO2 is 48, and your PO2 is acceptable, 55 in room air. So you're happy with that gas, but you're not happy with that PIP. You think that baby is requiring too much PIP. So when you put those numbers into the compliance curve, then you have a PIP of 24, you're using a PEEP of 6, you have a delta P of 18, and that gives you a tidal volume of 4.8 per kilo, and the compliance calculated, 7.2 divided by 18, gives you 0.4. It's a very low compliance. Why? Well, because you're overstretching those lungs. You're ventilating those babies with the lungs with excess volume. So how do you fix this? What do you do? If you can answer me, we'll see if you know what the answer is. But what I will do is decrease the volume. So if you decrease the volume, let's say just slightly from 4.8 to 4.5, what you're going to do is you're going to need only a PIP of 20. So now your delta P is only 14. You haven't changed the P, but you have moved those lines to a lower part of the curve. So you're not over distend those lines anymore. So your compliance now is better, went from 0.4 to 0.5. And just by doing that, your tidal volume is, although less than before, you are using significantly less pressure. You're ventilating those lines in a better part of the curve, and most likely your efficiency, your CO2 removal will not change significantly, but you're using a significantly lower PIP. Another example, you have an X-ray there of a baby that is intubated, and I'm very happy with, I don't know what those lines are, guys. It's not me. There you are. Anyway, you're happy with that X-ray. Lungs are well expanded. The heart size is good. No major issues. You're ventilating this baby with a PIP of 19/6. The tidal volume that you get with those pressures about 12.3, very good compliance, almost 1, and your delta P is 13. Now, all of a sudden, you do an X-ray, and the baby develops a upper right collapse, yes, secretions, whatever. So now the compliance curve have moved down. So you're not dealing with the same compliance curve. The compliance curve has moved to the right and down. So now, using the same ventilator settings, you are getting a volume that is significantly lower than before. And the compliance has moved from almost 1 to 0.6. So in this case, you're going to end up with significant problem with the CO2 and oxygenation because your lungs are deflated. So again, without changing the settings, you end up with significant higher CO2 and lower oxygenation, and therefore you need to do something to bring that curve up again. Another example, we have a 29-weeker, 1.5 kilo. This baby is 4 hours old. You give him surfactant ×1. But as you can see on that X-ray, those lines look very awful. So this baby has now responded well to surfactant. Okay, so you have this baby on ACVG, rate of 60, people 6. You're using volume of 5.2 per kilo, and that gives you a PIP of 19. You're using an inspiratory time of 0.3 seconds, and the baby is on 50% oxygen. You do a gas, the gas is reasonable, 727, CO2 is 56, and your PO2 is 55. But you're concerned because you're using a high volume and you're on 50% oxygen. Now, when you extrapolate those numbers into your compliance curve, you see that the compliance curve there is quite flat. Okay, so 19/6 gives you a delta P of 13, and that gives you a volume of 5.2 per kilo as you put it on the ventilator. And the compliance, which is 7.8 divided by 13, gives you 0.6, so a very low compliance. So how do you fix this? What do you do with this case? Well, unfortunately, you can't answer me. But what you need to do is you need to bring that compliance curve up. You need to improve the lung volume. And the way you do that, the easiest way to do that is by increasing the PEEP. Okay, so you increase the PEEP from 6 to 7, you move that curve up. Now, all of a sudden, using the same volume, but with a PEEP of 7, now you're getting a significantly lower PIP to deliver that volume, okay? And your compliance curve was moved significantly up. It's now 1.3 because you're using the same volume, but your delta P is only 6, okay? So what you've done, if you have moved that compliance curve up to the left and up, so all of a sudden these lungs are much better compliant, and most likely what you can do now is bring that volume down because you don't need that volume anymore. So just by increasing the P by 1 and moving the curve up, you could significantly make a difference in babies' settings. And I think I'm done. So if you have any question now, I'm happy to answer them, or we can discuss. It's something that you didn't understand or it wasn't clear, let me know and I'll try to go over again. Thank you.
Yeah, thank you, Dr. Alvaro. We have 10 minutes for questions. So if you have any questions, you can go ahead and unmute yourself. Yeah, and okay.
I don't have any questions, but I would like to thank Dr. Robin and Dr. Yasser and our colleague in Winnipeg for this really nice presentation. Thank you, Robin.
Yeah, thank you, Dr. Saad Sadi, for attending the presentations. Actually, our pleasure. And we'll hope that we'll continue attending our presentations in the future. Thank you. Any question?
Thank you, Dr. Alvaro. I have question. I'm Tariq from Saudi Arabia. I have one question regarding sedation in premature babies and the effect of sedation on chest recoil. And as we know, as you said, in preterm, the chest recoil is a problem already. And if I give sedation, I deprive them more from the chest recoil. What is your opinion about giving sedation in patient as a troubleshooting patient who is tachypneic? And thank you.
Okay. As I explained before, mechanical ventilation is not physiologic. Opening up the lungs with pressure is not physiologic. Okay. So the best, even when you are intubated, the best way to open up the lungs is to trigger those initial changes with spontaneous breath. So you basically initiate the movement of air by increasing the volume of the chest with a spontaneous inspiration. And that will make it closer to physiological. It's not going to be physiological because you're still pushing air into the lungs instead of sucking the air into the lungs. But at least you initiate that change spontaneously. When you use sedation and you eliminate those spontaneous breathing, you're basically making the lungs more exposed to trauma. So, and there have been many studies showing that keeping these babies paralyzed or keeping this baby heavily sedated, abolishing spontaneous breathing is not good. So if you use sedation, you try to use minimal sedation and try to maintain spontaneous breathing at all costs. Even if the baby is tachypneic. Tachypnea doesn't, that's the way the baby responds to poor compliance. They breathe faster. They can increase the volume. They breathe faster. Okay, and that's physiological for them, and that's actually better than decreasing the spontaneous breathing artificially with sedation. So at all costs, try to minimize sedation. Okay, especially narcotics.
Thank you for the presentation. Can I ask a question, please, regarding the last case you discussed on the volume pressure loop? We decided to increase the beep in order to increase compliance, but given the blood gas parameters and the baby X-ray, why we didn't think about giving a second dose of surfactant?
Yeah, no, that was an example just to, of course, in that case, you need to give a second dose of surfactant, although you have given a dose of surfactant 4 hours before. So you may want to wait a bit longer time to see if that first dose is still working. But that was just an example of how to change the volume of the lungs with your mechanical ventilation. Of course, you will consider giving a dose of surfactant, but in the meantime, when you're on 50% oxygen and your lung is deflated, it's not well expanded, you need to increase the PEEP. Okay, you can do both. You can increase the PEEP and give surfactant. Remember, it depends on what surfactant you use. Sometimes surfactant will take some time to work, so you can't just keep those lungs collapse. So you need to expand them, and the right thing to do is to increase PEEP and consider giving surfactant at the same time.
Muy buena charla, Rubén. Muchas gracias. Thank you, Yasser.
Yeah, he just left. He's on service, so he just left.
Hi, Ruben. Ganesh here. That was a great presentation. One question that when I was monitoring the chat was that one of the commentators mentioned like that individual is afraid to use a PEEP of 7. Is concerned about using a PEEP of 7 and how to get over PEEPophobia.
Right. Remember that that if you understood my lecture, you can only give excessive PEEP when the PEEP is more than what the lung needs. If the lungs is very stiff, going up on the PEEP is not going to damage your lungs. Okay, if it takes PEEP of 10 to keep the lungs open, that PEEP of 10 is not going to cause any problems. Okay. On the contrary, if that lung, because it's very stiff, has very low compliance, needs a PEEP of 10, and you're giving a PEEP of 8, then you're going to cause atelectasis trauma. And if that lung needs a PEEP of 10 and you give a PEEP of 12, yes, you're going to cause trauma. So you always have to decide what you think is the best PEEP for that lung. And the best way to know that is by looking at your graphics in your ventilator and look at your compliance. And what I do personally, sometimes I change the PEEP up and down and see what PEEP gives me the best compliance. And you can get that number from the ventilator. So you don't have to guess, okay? So you increase the PEEP, and if the compliance goes down, well, the PEEP is too high. If the compliance goes up, meaning that, yeah, that was a good move. So always use the ventilator, the graphics, and the numbers that the ventilator gives you to decide if your changing PEEP is good or not, okay?
Ruben?
Oh, yes, sir. Go ahead.
Ruben?
Go ahead, Molly.
Yeah, hi, Ruben. That was great. I have a question, and it relates to the latest thing that's come out from the EPIC group for the BPD bundle. And they're suggesting that for babies less than 800 grams, the tidal volume that we should be using initially should be between 4.5 and 5.5 mils per kilo. And the rationale is because of the dead space in the flow sensor. Now, I've looked in the literature, and I really can't find good, solid evidence for that, but I value your opinion.
Yeah, that's true. Remember that the range for physiologic volume in the normal newborn is 3 to 5.
Yeah.
Okay, so if a baby needs, and that's individual. So if a baby needs a volume only 3 per kilo, you can get away with only giving 4 or 4.5, even with a dead space from the transducer. Now, if that baby needs a volume of 4 or 4.5 per kilo, and you don't give at least 5 per kilo, you may be underventilating. So what I do, I usually try 4.5 per kilo and see what happens. If you're getting hypoventilation and your CO2 is up, I'm not afraid of going up on the volume. But if your ventilation, your CO2 level is good with 4.5 per kilo, there's no need to go up to 5.5. But you have to be aware that in the smaller babies, sometimes 4 or 4.5 per kilo may not be high enough. And don't be afraid to go a bit higher, because again, you're wasting most of your volume in the dead space on the flow transducer, okay, which is fixed. If you have a 500 gram baby, well, 30% of that volume will be wasted in your flow sensor. So don't be afraid on those tiny babies to go out to 4.55, because that's not what the baby is seeing. It's not what the baby is receiving. Okay. So.
Hey, Ruben, it's Moshe from Calgary. A quick question with the current, non-invasive strategies. Even after extubation, as we talk about the PEEP phobia, so how much PEEP is I'm just going to go to, people are using PEEP of 10, 12, 13, 14 after extubation. Is there any specific limit we should be worried because we don't have the tidal volume to monitor after extubation?
Right. I don't think we know the answer to that. Definitely those babies that, chronic babies with BPD, their lungs are quite stiff, the airway resistance is quite high, and those babies need much higher PEEP than what we used to use 10 years ago. Okay, so it's not unusual to see a baby with chronic lung disease requiring PEEP of 10, 11, 12, 13, 14 sometimes. Okay, again, what the limit is, we don't know. But if depends, the lungs are very stiff and the airway resistance is very high, you could be safe using PEEP higher than that. So it's hard to know. You always have to see, looking at the FiO2, looking at the lung volume X-ray and the ventilation, and see if your PEEP is too high or not high enough. But I don't think we are still afraid of going much higher than 12, 13, but we don't know if really that's harmful or not. Every lung is different. So
yeah, just may I add to your comment, Ruben, that we have a misconception that whatever pressure you give will be translated into the baby's lung, which is not really wrong, will be translated into volume. So if the lung compliance is very poor, whatever pressure you will give will be lost in the poor compliance. And whatever you get at the end is just the volume that the lung can maintain, and that you need to do either X-ray or lung ultrasound or whatever, or check the venous return by echo. But it can be very high pressure needed, and just the delivered volume will be at the end very small because of the poor compliance.
Just to give you a comment to this, I have a friend, intensivist in New York, working with coronavirus patients, and I was talking to him yesterday, and he said in adults you never use a PEEP higher than 11, 12, the most. He's telling me that in these patients they are using PEEP of 25 sometimes, okay, and they are not breaking the lungs. Because the lungs are they get so stiff with coronavirus that they are using PEEPs that they never used high before. So again, he's completely surprised that these people can tolerate PEEP up to 25. So I wouldn't be surprised if some of our babies meets PEEPs higher than 12, 13, because as Yasser said, not all that pressure is translating to the lungs.
So just one word of caution there is that the chronic lung is a lung which needs the resilience is a good lung, but in the acute situation, when in the initial days of our preterm baby, in the first few days, one should be careful about going up very high on the PEEP, the numbers that Ruben is suggesting, because those babies, there is documented evidence of Michelin baby, pulmonary interstitial emphysema, air tracking that can take place even cutaneously. So, put this in perspective. The lung of a first 2-day, 3-day baby is not the same as that of a chronic lung disease baby, is not the same as a lung which is injured due to some other condition earlier. So if you put in all the information, apply your physiology, understanding of the timing of the disease process, and integrating that with the other X-rays and ultrasounds, then you will come up with a better idea. I don't want you to go home with a message that the PEEP of 14 is okay for a first 3-day baby, but in different conditions, there are different. So it's not the number that is important, but the lung condition.
I agree 100%. In the first 24 hours, I don't think using a PEEP of higher than 8, it's reasonable, because if you have a baby that needs PEEP of higher than 8, that baby needs surfactant, okay? And don't keep going up on the PEEP thinking that you're going to fix the problem with PEEP. You may transiently get the lungs a bit more open, but definitely those are not the babies that will go very high on the PEEP. I will give surfactant and try to give the PEEP in a reasonable level, 7, 8 at the most. Yeah, I agree 100%. We're talking about chronic babies with very high airway resistance. Remember, our babies in the first few days, the airway resistance is very low, and all the PEEP you are using through the nose is fully transmitted to alveoli. It's not the same as babies with BPD with high airway resistance. Okay.
Yeah, unless you have like heterogeneous disease like meconium aspiration during the first day or two, that might also apply to lung, might require higher pressure, regardless you get surfactant or not.
Right. Ruben, one of the questions I was monitoring from the chat is there was a question asked whether the high PEEP can lead to gaseous distension, and what do you do about that? How do you manage the PEEP and the gaseous distension? And that was a question, like when you go high PEEP, do you have to worry about gaseous distension?
Yeah, well, that's a challenge, especially sometimes we have these babies on continuous feeding, unable to vent the stomach. So yeah, you have to, you can't ignore that. That's a significant issue sometimes. Again, it depends on the anatomy of the airway. In some babies, when you apply PEEP through the nose, most of the pressure goes straight to the lungs. But in some babies, a lot of that pressure goes into the stomach, and you need to be aware of that. So you need to find a way to vent the stomach properly, okay? Otherwise, you can get into trouble. And sometimes it's difficult to give those babies on continuous feeds because you have no time to vent the stomach. So that's important too.
The recording has stopped.
Hi, Ruben.
Hi.
Hi, how are you? I'm Jubara.
Oh, hi, Jubara.
Nice to have you and all of you. I just have a small question regarding the volume, pressure volume curve during non-invasive ventilation.
What's your question?
The question, how to measure the dynamic pressure volume curve during non-invasive ventilation for newborn?
Oh, I don't think you can, unfortunately. Now, there is a device, I think is from Italy, that is using a flow transducer through the nose. And I don't know if you can accurately measure tidal volume on with that transducer. I don't have experience with that, but we personally, we don't have a way to measure tidal volume when you're using non-invasive ventilation. So there's no way. So I don't think anybody has done a study in humans that reliably measure tidal volume non-invasive ventilation. So that's a problem because, and again, even if you are able to measure tidal volume somehow, you can't tell how much of that volume actually goes to the lungs and how much volume goes somewhere else. So it's not going to be reliable, really.
Yeah, I think the transducer is meant to measure the transmural pressure, the esophageal group.
Yeah, I guess you could measure transmural.
Which will be
you can do that. Yeah, but that would be invasive and it's not clinical. It's only for research. Yeah. No, that has been done, of course. You can do that, but not in the clinical settings. Yeah. So maybe with NAVA, because NAVA is already using esophageal transducer, potentially you could measure compliance with NAVA, but I'm not aware that that has been done.
Hello.
Yes.
Hi, Robin. This is Abdullah from Riyadh, Saudi Arabia. Abdullah Taib.
Oh, hi. Nice to hear from you.
Nice to hear you also. I enjoyed this lecture. It's very nice, really. And thank you, Yasser, also, and Ganesh. I have a question. Here, post-cardiac surgery, we are receiving many patients with open chests, very complex cardiac surgeries. And some of these babies coming with open sternum, that they will keep the sternum open for 1 or 2 days till the chest wall edema subside, and then hemodynamics get better, and then they will close the sternum. My question, in this situation, if I receive a baby who is open sternum and having collapsed lung, starting to collapse the right upper lobe or left lobe, how I'm going to manage this baby respiratory ventilation? I mean, in your calculation of this intrathoracic pressure, extrathoracic pressure, and
okay. Now, remember that when you have open sternum, you don't have an open system. It's not like an pneumothorax. Okay, you still have that negative pressure pressure in your pleural space. Okay, so the chest wall compliance may change, but the pleural pressure is still there. It's negative. Okay, so the principle that is going to be the same as when your chest is closed. You may need higher pressures because you don't get the recall of the chest wall as good as when your chest is closed, but you still have the negative pressure in the pleura unless you have an pneumothorax or something. So you have to use the same principles. Okay? I don't think that changes. I mean, I don't have a lot of experience with open chest ventilation because we don't have cardiac surgery in Winnipeg, as you know, but I don't think that physiology changes a lot when you have open chest.
Why I ask that? Because people in our experience, they are getting very afraid to increase the beep above 4 when we have an open sternum. Despite there is collapsed lung.
Yeah, people 4? I don't think we ever use people 4.
Beep 4, 5, beep 4, 5 maximum. All the people here is getting scared when they exceed 5 in an open sternum. Although I'm insisting to increase the beep, but people is telling no, this sternum is open. And sometimes we are receiving babies from surgery with beep of 3 and 4.
Yeah, I can just add a comment for that. To reassure them, Abdullah, you can actually check by echocardiography the venous return. Venous return, right atrial pressure is very sensitive to increased pleural
intrathoracic pressure.
Yeah. So the pleural pressure turn positive or high positive, that will be affect the venous return will stop. So you can always check and reassure them that once whenever you have the pulmonary venous return maintained, and you can see a good Doppler for pulmonary venous return between 0.2 to 0.5, meter per second, that's reassuring that
exactly
the pressure is not really affecting the venous return, and even if you have room to go higher.
Yes, correct. Thank you so much.
Also, to add a comment, these babies are coming with LA lines and central venous line, so you have already the hemodynamics monitored invasively, and these babies already going to surgery with a normal lungs, so it's a transient effect, and they don't need any much pressure ventilations.
Yeah, that's a good point. Yeah. But at least to optimize the lung ventilation is required.
Another question regarding this peepophobia. Why the people is afraid from giving high PEEP? And in fact, if we have difficulty in ventilating this patient or difficulty in oxygenation, we are shifting them to high frequency, which was oscillatory ventilator, which my understanding is high frequency is giving high PEEP and giving amplitude around this PEEP. So why the people is not afraid from high MAP on high frequency and they afraid from PEEP in conventional?
Yeah, you have a point there, and you have to ask those people, because I don't have an answer for them. But we have come a long way. I think we understand how PEEP works in babies, and the main concern when using high PEEP is not just the high PEEP, is the tidal volume that you add to the PEEP. Okay, with high frequency, you're basically use the PEEP is the minimal pressure. Okay. When you use CPAP or PEEP on a mechanical ventilation, then your minimal pressure is much higher than the PEEP. So you can extrapolate both. Okay, so and what determines decreased cardiac output is in minimal pressure, not just PEEP. So if you're using a high PEEP and on top of that you're giving a high tidal volume, your minimal pressure will be much higher, and that minimal pressure is maybe the one that gives you problem with cardiac venous return and so on. So with high frequency, the minimal pressure used, that's the minimal pressure, okay? Because the frequency cancel each other, or at least on the oscillator. On the jet, it adds a little bit, but the oscillator cancel each other. So your minimal pressure is your PEEP, okay? But again, I have no answer for those people that are afraid of giving enough PEEP. I'm against giving more PEEP than the baby needs, but the need for PEEP, it could be much higher than what people think is safe. Okay, so.
Okay, any other question?
We are waiting for your next lecture about high frequency ventilation, Robin.
Okay.
Okay. Yeah, we'll be on the list. So we'll just wait for announcement. Some of you asked about the recorded version of the presentation will be available on the Focus New website. Okay. Thank you for everyone for joining us. Yeah, thank you.
Nice to see you all.
And it's really nice to see you all, and hope you'll see you again soon in another presentation.
Stay safe.
Okay. Yeah. Thank you very much.
Okay.
Thank you.
Bye.
Thank you.
Thank you. Thank you. Thank you, Doctor.
Thank you.
Thank you. Thank you, Dr. Yasser. Thank you so much.
Dr. Yasser, thank you very much. Thank you.
Thank you, Dr. Thank you, Dr. Robin, too. Thank you.
Many thanks.
Thank you.
Many thanks.
Thanks. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.